For my case study, I had a rest-only myocardial perfusion study. The original goal was to obtain both rest and stress images, but as we all know in clinicals, things don't always go as planned. Here is the copy of the permission form for the de-identified images signed by my clinical instructor, and the images may be retained by Gateway Community College. The case study involves a 66-year-old African-American male who was referred to the cardiologist due to a gassy feeling felt in his chest whenever he works out. This gassy feeling has been felt over the past couple of months. The cardiologist ordered a rest and exercise stress myocardial perfusion study to evaluate for coronary artery disease. When explaining to the patient why the test was ordered, the patient showed reluctance to go through with it, for he insisted that it was a GI issue, not a cardiac issue. But he agreed to go along with the test regardless. In preparation for the test, the patient has not had any caffeine for the past 12 hours, and he is not on any beta blockers or blood pressure medications. He is able to lay on his back with his arms above his head for the imaging, and he is not traveling across state lines or out of the country 3 days after the test, so a radioactive test note was not necessary to give to him. Since he was in exercise stress, it was important to see if he was taking any beta blockers or blood pressure medications, because this may affect him reaching his target heart rate. If he was on a beta blocker, we wouldn't necessarily reschedule the test, but we would let the cardiovascular technician know and inform the patient that it was possible that if he doesn't reach his target heart rate, we may have to perform the stress portion of the test at a later date, making sure he's off his beta blockers prior to the test if it's okay with the doctor. Here is a copy of the informed consent that the patient signed prior to the test. In short, this consent form gives us permission to perform the test. Feel free to pause the video if you wish to read the consent form in its entirety. I just wanted to give a brief overview of what a rest-stress myocardial perfusion study was. According to the SNMMI, a rest-stress myocardial perfusion study is a type of stress test that uses PET, or in this case, SPECT imaging of a patient's heart before and after exercise to determine the effect of how stress affects the flow of blood through the coronary arteries and heart muscle. According to a peer-reviewed journal from the Indian Journal of Nuclear Medicine, coronary artery disease is the leading cause of morbidity and mortality worldwide. Gold standard for the evaluation of epicardial coronary artery disease is invasive coronary angiography. However, myocardial perfusion imaging demonstrates the cumulative effect of pathology in the epicardial coronary arteries, small vessels, and endothelium. MPI imaging can evaluate the overall burden of ischemic heart disease. What does an MPI study evaluate? It evaluates the overall function of the heart muscle and individual heart walls, damage to the heart muscle following a heart attack, diagnose symptoms of coronary artery disease, such as shortness of breath and chest pain, determine the extent of coronary stenosis, determine if the patient is a candidate for revascularization, manage the treatment of CAD following revascularization or drug therapy, and preoperative risk stratification, whether or not the patient can handle anesthesia, etc. Not necessarily related to this case study, but I did have a patient come in for a myocardial perfusion study prior to a hip replacement, which I found that was interesting. The day of the study. The day of the study, I greeted my patient and brought him back to the injection room and explained the study. Like I mentioned on the patient history slide, I made sure that the patient did not have any caffeine within the past 12 hours, asked if he was on any blood pressure medications, and asked if he was able to lay on his back with his arms above his head for imaging. And lastly, I asked if he was traveling out of state 3 days after the test. I then told the patient to plan to be in the office for about 3.5 hours. I placed into the IV catheter, which is this guy right here, in his left antecubital fossa, and administered 9.1 millicuries of Tec 99M cestamide, followed by a 5 cc saline flush, and wrapped the catheter up in a Coban to make sure it was secure. I then walked the patient to the nuke med waiting room and had him drink about 10 to 16 ounces of cold water to help flush out the radio tracer from his liver, and told him we will be taking his rest images in a little over an hour. A little over an hour later, I brought the patient into the imaging room, and I had him lay supine with his arms above his head and his knees propped up on a wedge, just like the picture shown. I then placed a 3-lead EKG on the patient for gating. At my site, we have a GE cardiac camera. I then positioned him underneath the detectors and told him to lay as still as possible and breathe normally. I then acquired SPECT images of his heart, which was about a 9-minute acquisition. He had a lower body mass index, so we were able to knock off a couple minutes off of his imaging. After the acquisition, I got the patient up and brought him to the stress lab for the stress portion of the test. In the stress lab, the cardiovascular technician attached the patient to a 12-lead EKG and placed the patient on the treadmill for a Bruce protocol. According to our Waterstone-Rich textbook, exercise remains the preferred method of stress for patients who are able to achieve adequate levels of exercise. The treadmill is the most common method of exercise in the United States. However, in Europe, an upright bicycle is preferred. What is a Bruce protocol? During the Bruce protocol, the patient is placed on the treadmill and the workload of exercise is increased every 3 minutes. This is done by increasing both the speed and the incline of the treadmill. Every 3 minutes, the workload increases until an adequate level of exercise is achieved, which at minimum is 85% of the patient's maximum predicted heart rate. This is calculated by subtracting the patient's age by 220 and multiplying that by 0.85. The patient in this case study was 66, so 220 minus 66 times 0.85 equals 130.9 beats per minute. It was rounded up for 132 beats per minute for the test. So, once the patient reaches a minimum of 132 beats per minute, you can inject the booster of the radiopharmaceutical to achieve the rest images. But things did not go as planned. The corresponding study for my case study will be the EKG done during the stress test. You can already tell the EKG is abnormal. It doesn't look as pretty as it should, but I will talk about the actual EKG later on in the presentation. But on this slide, I wanted to point out the highlighted section of the EKG pages. Right at the start of the Bruce protocol, which is less than 3 minutes on the treadmill, the patient started to complain of slight chest pain. On stage 2 of the Bruce protocol, which is between minutes 3 and 6 on the treadmill, going at 2.5 miles per hour at a 12% slope, the patient started to have chest pain rated 4 out of 10, which is what the EKG page is showing. Before the test was started, the patient's blood pressure at rest was 132/88. At this stage of the Bruce protocol, his blood pressure was 162/90. Keep in mind he is not very far into the test. Before moving on to the next page of the patient's EKG, I wanted to show you what a normal EKG might look like. Just take a minute to look at those waves, and you can pause the video if you'd like to study those different waveforms. Now, here's a snapshot of the patient's EKG. You can tell it's a little out of whack. Here's a normal EKG. Here's the patient's EKG. This is stage 3 of the Bruce protocol. The patient is going 3.4 miles per hour at an incline of 14%. Blood pressure is 170/90, and his heart rate is 100 beats per minute. And he is struggling with chest pain, rated 8 out of 10. The patient is not even at his target heart rate, which is 132, so we can't inject the radiopharmaceutical. Due to the EKG abnormalities and high chest pain, the cardiovascular tech shut down the test and had the patient sit down to rest. Once resting, the patient's chest pain started to dissipate, and I showed the cardiologist the EKG to see if he wanted to convert the stress portion to a chemical stress test. The cardiologist decided to end the test then and there without achieving stress images based on the EKG. And I'll show you the page where he decided that the stress images were not necessary for diagnosis. Just wanted to show you a quick review of EKG interpretation. Your standard EKG line is made out of the P wave, the QRS complex, and the T wave. The P wave is atrial depolarization. This little bump signifies when the atria of the heart contract. The QRS complex is ventricular depolarization, where the ventricles contract. The T wave is ventricular polarization. This is where the ventricles relax. Atrial polarization, where the atria relax, is not often seen on an EKG. It takes place after the P wave and is found somewhere within the QRS complex. Ventricular depolarization overpowers atrial repolarization, so to speak. So atrial repolarization often is not seen on an EKG line. Now, there are a lot of different segments and intervals that we can discuss in regards to EKG interpretation, but for this case study, I wanted to focus on the ST segment. The ST segment starts at the J point and goes until the beginning of the T wave. The ST segment represents the interval between heartbeats. The cardiologist decided not to convert the test over to a chemical stress test and achieve stress images due to ST depression seen on the EKG. On a normal EKG, which this is an example of, the ST segment will be in line with the baseline. I went ahead and drew the baseline on this normal EKG picture. It is the blue line here. The ST segment was if the ST segment was above the baseline, that'll be known as ST elevation. If it's below the baseline, that'll be known as ST depression. Looking at the patient's EKG during the recovery phase, so he's off the treadmill, chest pain is still 8 out of 10. The cardiologist marked the area of the EKG that made him determine that the stress images were not necessary for diagnosis. Let's zoom in on that section. Zooming in on the EKG and focusing on the ST segment of the EKG, we can see that the ST segment is well below baseline. This is baseline. This is the ST segment. An ST segment that is below baseline, along with the other symptoms he's having, such as exercise intolerance and chest pain, is indicative of coronary artery disease. If there was an ST elevation, for example, so if the ST segment was above baseline, that would be indicative of ischemia. Even though the patient had chest pain 8 out of 10, the patient still insisted that it was gas and not a GI issue. Before getting into the nuke-med images, I wanted to review the different slices that are generated during processing and what vessels supply the different walls of the heart. This is a poster that hangs just above the processing station at one of my sites, and I found it very useful when looking at the different slices of the heart that are generated during processing. The names of the walls and what vessel supplies each wall are clearly labeled on this poster. Feel free to pause the video to examine this poster. Now let's finally look at the images obtained in this case study. So these are rest-only images, and the short axis, the vertical long axis, and the horizontal long axis planes are shown. Looking at the short axis plane, there is some limited perfusion along the inferior wall. So, inferior wall, some limited perfusion we can see here. Looking at frames 14 through 17 on the short axis plane, you can see the septal wall disappear. So right here, you can kind of see that the septal wall is disappearing. One might think that may be due to lack of perfusion, but on a SPECT slice, as they're generated, the sternum kind of attenuates that area as it's going around the patient. Looking at the vertical long axis set of images, you can once again see that the inferior wall isn't perfusing as well when compared to the anterior wall, which is at the top and then the apex. So the inferior wall right here, not perfusing as well compared to the anterior wall, as well as to some as well as the apex in some slices. But the apex isn't as pretty and well perfused as it should be either. Now we're going to look at the horizontal long axis plane. They're more or less normal. In frame 6, I kind of have everything a little cut off, I apologize. You can see some limited perfusion along the apex. So, based on these images, the inferior wall and the apex of the heart are affected, which is indicative of right coronary artery disease. For the right coronary artery supplies blood to the inferior wall of the heart, as well as the apex. This is the function page of the MPI study. In quote-unquote real life, this picture right here, all these pictures, will kind of be pulsing to show contraction, like a little cine movie. They'll be pulsing to show contraction and relaxation of the heart during gating, but the PowerPoint application wouldn't let me upload that file, so I had to take a screenshot instead. But on this page, I wanted to focus on the values generated in this study. The main value of interest is the ejection fraction, or EF. That is the percentage of blood that leaves the heart every time it contracts. In order to calculate the EF, you must first know the end diastolic volume and the end systolic volume. This is a zoomed in on the calculations that we're going to be looking at, and I have some formulas here. First, you want to take the end diastolic volume, which is the amount of blood that enters the heart during diastole, or relaxation, and subtract that from the end systolic volume, which is the amount of blood remaining in the heart at the end of contraction. So you take the end diastolic volume minus the end systolic volume, and that difference equals the stroke volume. The stroke volume is the volume of blood pumped from the left ventricle per beat. So, looking at this, his end diastolic volume was 107 milliliters. His end systolic volume was 32 milliliters. The difference of those two is a 75 milliliter stroke volume. Now, to get the ejection fraction, which is our main goal, you take the stroke volume and divide that by the end diastolic volume. Take that difference and times it by 100 to get your ejection fraction. So, 75 milliliter stroke volume divided by the 107 milliliter end diastolic volume times 100 equals 70%. Any ejection fraction greater than or equal to 50% is considered normal. Anything less than 50% is abnormal, and anything equal to or less than 12% can get a patient on the heart transplant list. So, this patient's ejection fraction was 70%, which is normal. This next slide is the tech worksheet that I used to put information on for the cardiologist while they read the study. Under the notes, you can see I put chest pain, 8 out of 10, and EKG changes during treadmill exercise. Stress stopped. Per the doctor, cath advised. Stress radiopharmaceutical not injected. I inserted the values right here for the rest, so you can see that we have the ejection fraction, the end diastolic volume, and the end systolic volume. Now, we weren't able to place any values here, as well as here, because we had no stress images and calculations to compare it to. Under the gating and reconstruction notes, my QC for the gating was yellow, so when I opened up that, it showed that there was low count rate in bin 8, which happens a lot at my site. It doesn't make the gating as pretty as it should, but it doesn't affect the images too bad. Now, it says right here that we gave 30.1 millicuries of stress radiopharmaceutical, but that was not injected. I placed that right here as well. Now, let's look at the cardiologist report. Imaging protocol. This was a gated SPECT myocardial perfusion imaging study. Let's take a look at that. We used 9.1 millicuries to obtain these images. The reason for this exam was due to chest pain, rest-only images were performed, the ejection fraction was 70%, and there was possible inferior infarct versus diaphragmatic attenuation. So the patient had an inferior and lateral ST segment depression and angina, which is chest pain, limiting exercise to a sub-maximal heart rate. So he never achieved his heart rate of 132 that we were shooting for. Due to his chest pain out of 8 out of 10, it was a high-risk test, and that the doctor advised a left heart cath this week. The patient was instructed not to exercise and seek emergent attention if symptoms worsen. Once the patient's chest pain was gone, he was discharged. Quick little note, the doctor advised him not to exercise previous to this test as well. But like I said, the patient was convinced that it was a GI issue and not a cardiovascular issue. So I really hope that he went for this left heart cath and he stopped exercising until the doctor said he could. Let's take a look at this response to stress. Due to his exercise limiting angina, he had a high treadmill score of 11, which was pretty high, so that the test was stopped. Feel free to pause the test, pause the video if you need to look at this a little further. This is the last page of the cardiologist report. It just shows the values that I plugged in during processing. The reason why I chose this particular case study was mostly due to the EKG. The fact that the cardiologist didn't switch the test over to a LexiScan based on EKG changes alone made me wanted to look into it. And plus, I wanted to brush up on my EKG interpretation, so this was the perfect excuse to relearn those different segments and what each little bump in the EKG line means. Ideally, to make this study more better than it would have been, it would have been nice to have some stress images. It would have been nice to compare both the rest and the stress to see, if that inferior wall defect that we saw in the rest images fills in more during stress. But it was a very interesting case regardless. Here are the references I used for this presentation. Thank you so much for listening. I hope you found this as interesting as I did. And if you have any questions or comments, please comment below. I'd love to get to them. Again, thank you very much for listening. Have a good one.